Thank you very much. I appreciate the opportunity to represent the American College of Cardiology in participating in this ACC Saudi Heart Association symposium, and have been charged with talking about genetics and the management approaches to hypertrophic cardiomyopathy. I thought I'd take advantage of the opportunity to go a little bit broader beyond the genetic part of it because, frankly, the role of genetics, as you'll see, is relatively limited in the management of this condition. And it's always helpful to start with a case to give clinical context and, in particular, to help the clinicians remember the key points about genetic testing and management otherwise. So this was a recent patient I saw. It was a 19-year-old collegiate hockey player who was referred for a syncopal spell. He had palpitations prior to the loss of consciousness. His history, physical, family history, EKG, and stress echo were normal. But he had a normal TDI, normal LV function, and his left ventricular wall thickness was normal. But an MRI was done at an outside hospital. Now, this is his EKG, which showed high voltage, common in athletes. His echo is shown here with an interventricular septum that measured 1.4. Right at the margins of normal, perhaps making it difficult to distinguish between an athletic heart syndrome and physiologic hypertrophy versus hypertrophic cardiomyopathy. But the MRI, as you can see, showed a small amount of enhanced gadolinium, indicating that there was some scar. So this is an equivocal case of possible hypertrophic cardiomyopathy in which genetic testing, as you'll see, was performed. So he was deconditioned for 4 months, and echo showed no change. The late gadolinium was still present, creating quite a bit of a dilemma, because if you misdiagnose, you could unnecessarily label him for a lifetime and restrict him from athletics. Genetic testing was negative in this patient. Now, one of the key points about genetic testing is that absence of a mutation in a proband, a patient identifying potentially with hypertrophic cardiomyopathy, is considered indeterminate, and it's of no relevance for clinical screening. Okay? This is one of the key points from this session. Nonetheless, we felt we had sufficient information to diagnose hypertrophic cardiomyopathy. We restricted him from athletics, screened the family clinically, but not genetically, and an ICD is being considered in this young athlete. Now, if there is a take-home message about genetic screening with hypertrophic cardiomyopathy, it's as follows. In a patient in whom there's uncertainty about the diagnosis, going down the right side of the slide, what you can see is that genetic evaluation is reasonable. In this individual, it was not helpful because it was negative, as it is in about 2/3 of individuals with hypertrophic cardiomyopathy. If it had been positive, it would have been reasonable to confirm the diagnosis and then go on for genetic screening in the family members, only if there was a pathogenic sarcomeric mutation. So in individuals in whom there's some equivocation about the condition itself, genetic testing can be helpful, and 1/3 of the time is diagnostic. When you have an individual sarcomeric abnormality, you can then go on to screen other family members specifically for that sarcomere. So, genetic screening is often not productive. Genetic testing can lead to definitive diagnosis in these gray zone cases. And in addition, the genetic testing can be used to screen family members as well. Now, historically, I thought I'd put this in some context because this is a relatively new condition. It's one which was originally described in the late 1960s at the National Institute of Health by Dr. Marin, Dr. Eugene Breinwald as well. And in this, the original condition described as hypertrophic cardiomyopathy or idiopathic hypertrophic subaortic stenosis was one that was associated with an outflow tract gradient. It's an intrinsic myocardial disorder with unexplained LVH in the absence of pressure overload, storage, or infiltrative diseases. And commonly, there are conditions such as amyloid or Fabry's disease, which can mimic hypertrophic cardiomyopathy. It's an autosomal dominant with variable penetrance. It's a relatively common condition, about 1 in 500 people, and is a very heterogeneous clinical presentation, all the way from lack of physiologic hypertrophy to severe hypertrophy with septal thickness that's up over 3.0 centimeters. The natural history is frequently very benign. The people who get referred to referral centers are at higher risk for heart failure, atrial fibrillation, and sudden cardiac death. So selectively, individuals in the literature are those referred because of higher risk conditions. There's many anatomic manifestations of it. Beyond just the septal thickening, you can have thickening at the apex, you can have thickening of the free wall, and increasingly with imaging modalities such as MRI, it's apparent that this is not limited to the basal septal thickness. There's a very diverse pathophysiological and variable presentations all the way from sudden death in young individuals who previously had been undiagnosed to progression over many decades to a dilated myopathic process with systolic heart failure. The natural history is benign to malignant, and genetics give very little information about the prognosis in the individual patient. Now, importantly, there's two types. There's obstructive with systolic anterior motion and mitral regurgitation, which is about 70%. And there's also people who have diastolic sequelae with dyspnea, fatigue, with preserved left ventricular function in the absence of it, so-called HFrEF, with HFpEF with preserved ejection fraction. And the treatment of these conditions is extremely challenging with respect to heart failure symptoms. The pathophysiology of one in which there is microvascular dysfunction, ischemia, manifesting itself clinically with either sudden death, heart failure, atrial fibrillation, and a very high frequency of embolic events with strokes. So there's three prognostic profiles which are highly variable: a benign one in asymptomatic individuals with preserved ejection fraction, normal quality of life, and normal life expectancy. Most of the patients present with an intermediate risk of atrial fibrillation, in which the risk of stroke is high and anticoagulation is mandatory, independent of the CHAD score, even with a CHADS VAS score of 0. And also with heart failure. And in these individuals, you treat them based on the pathophysiologic basis of their heart failure. Now, the more malignant risk of these individuals with sudden death, heart failure, and stroke is one in which we treat to try to prevent progression of heart failure, prevent progression of risk factors for sudden cardiac death, and the only mechanism we have of preventing sudden cardiac death is with implantable cardioverter defibrillators. Pharmacologic therapy plays no role. Now, in those with obstructive physiology, it's very important to assess for symptoms. As always, the treatment of these individuals is based largely on their symptomatic status. And as if you know, if they have no symptoms, we just follow them clinically. If they are symptomatic in these individuals, we treat with beta blockers, verapamil, and disopyramide in an effort to decrease the outflow tract obstruction. If they have persistent symptoms, we have the option of alcohol ablation in the cath lab, surgical myotomy, and a very select group of patients, one can go on also to use pacing. Now, in the absence of obstruction in these individuals, one can simply follow them clinically if they have no symptoms. If they do have symptoms and they have preserved systolic function or decreased systolic function, we then give them optimal medical therapy with ACE inhibitors, beta blockers, and diuretics as appropriate. And with preserved ejection fraction, we consider beta blockers, verapamil, diuretics, ACE, and ARBs, but as this group knows, the response to them is really quite poor. Now, what about ICDs? Well, ICDs in these individuals are really key, and it shows the point where registries are extremely helpful because there have not been any prospective randomized trials. So with a prior cardiac arrest or sustained VT, no question about it. In those individuals who have risk factors, such as left ventricular wall thickness greater than 30, syncope, non-sustained VT, or a blood pressure decrease, a single risk factor in many of them is considered to be adequate. Clearly, if they have two risk factors, one would have a 2A indication. 2B would be a single risk factor And you may use the gadolinium enhancement not as an independent risk factor, but to further risk stratify if they have a single risk factor in this patient population. And certainly the ICD should not be recommended if they have no risk factors and no prior cardiac arrest. Now, if we look at the relationship between the number of risk factors and appropriate ICD firings, data which we published now back in JAMA some 6 years ago, you can see that there's a difference between 1, 2, and 3 risk factors, but the statistical significance of this is non-significant. So a single versus 3 risk factors versus 2 risk factors clinically in a very large group of patients from pooled data from a dozen centers, both EU and US centers, so there's no difference between a single, 2, and 3 risk factors. And this is different than what has been found with the ESC guidelines, who typically recommend 2 risk factors. In the AHA-ACC guidelines, a single risk factor is sufficient. Now, if we look at mortality by age, notice that the yellow group, young age group, tend to die early. They're undiagnosed. They frequently die with athletic competition. As people get older, there's a higher risk of heart failure, and then particularly with advanced systolic dysfunction and atrial fibrillation, a high risk of stroke, bringing home the issue that these individuals, in fact, need anticoagulation with any episodes of atrial fibrillation. Now, MRI has evolved in these individuals. In this particular instance, shows left ventricular hypertrophy involving the anterior septum from 36 millimeters, which by itself is sufficient to say the patient's at high risk. It extends also in the anterior lateral wall. And in these individuals, here's another example with 4-chamber slice showing hypertrophy confined to the left ventricular apex. And in this instance, there's enhancement in the basilar area of the anterior septum. So increasingly, we're recognizing the heterogeneity of anatomic manifestations of hypertrophic cardiomyopathy with advanced imaging techniques, which should be used, MRI with gadolinium enhancement, in any patient who has potential diagnosis of hypertrophic cardiomyopathy. The echo alone is insufficient. So, what about clinical outcomes of hypertrophic cardiomyopathy in patients over 60 years of age? Well, this is important data, and it basically shows that in these individuals who have hypertrophic cardiomyopathy diagnosed at age 60 or over, they have a very benign prognosis. They have already been selected as being survivors without sudden death, without heart failure, without atrial fibrillation. And the clinical outcome in these patients shows that it's very, very benign. So one needs to be very selective about implementation of risk stratification strategies for sudden cardiac death in individuals over age 60. And looking at the Kaplan-Meier forms for hypertrophic cardiomyopathy in those greater than 60 years of age versus the general population, there was no statistically significant. There's a higher risk of heart failure and atrial fibrillation and stroke, but no statistically significant risk of sudden cardiac death. So a few words about the genetics. They're very complicated. There are more than 1,000 distinct mutations. About half of people have no mutations, and diagnostic mutations are found, frankly, in only about 1 out of 3 patients. Because of this heterogeneity, there has not been very robust genotype-phenotype relationships. And based on that, one needs to be extremely selective about the genetic screening and using it only under 2 circumstances. 1, when there's diagnostic uncertainty despite full clinical evaluation, and if it's negative, it's not helpful. And 2, in an individual who is presenting with clear manifestations of hypertrophic cardiomyopathy or equivocal cases in whom you find a sarcomeric mutation that's diagnostic of hypertrophic cardiomyopathy, you can then selectively screen family members for that gene and that gene only. And those are the 2 circumstances where it's clinically useful. And this point, of course, has come out. Here's a 27-year-old female whose genotype based on hypertrophic cardiomyopathy is genotype positive, but phenotypically she's negative. Now, there still is a controversy about whether that patient has the condition or not. And in that regard, we don't know. Now, the Europeans, for example, say this individual who's phenotypically negative but genotypically positive should be excluded from athletic competition. By contrast, in the United States, we allow phenotypically negative, genotypically positive to compete with athletics. We simply don't have sufficient robust data about genotype-phenotype relationships to know how to manage these patients. And by contrast, here's a 33-year-old with development of left ventricular hypertrophy and Sam who's phenotypically positive. So there's a variable expressivity based on age and penetrance, and there's probably facilitator or inhibitor genes that come up in these individuals that we're just beginning to get clinical insights into. So the least clinical utility in those in whom there's no mutation identified, and the greatest clinical utility is in those who have a pathogenic mutation. But frankly, about half of patients have no mutation, and about 25% of patients have known what's a VUS, a variant of unknown significance. Not normal, but not associated with hypertrophic cardiomyopathy. So genetic testing is done on a very, very limited basis, and it needs to be thought through very carefully about how you're going to be using that information. So this represents those individuals who have no mutations identified but have positive phenotypic manifestations of hypertrophic cardiomyopathy, about half of patients. It's only about a third who have pathogenic mutations, and this variance of unknown significance is up at about 20 to 25% based on contemporary data. We've been through this before, but it merits emphasis. Genetic testing is often not productive. Genetic testing can be used in gray zone cases, such as the patient I sent with his equivocation about whether the patient has hypertrophic cardiomyopathy. And if a patient's identified with the gene, one can then use that selectively to screen for family members. But there is a lot of controversy. And in general, there's controversy in any area of cardiovascular medicine when we have insufficient data. And there are unresolved issues relating to sudden death profiling, management strategies, competitive stressing, competitive sports relative to this genotype-phenotype relationship. So genetic testing should be considered in a family matter rather than an individual test. Screening is recommended in first-degree relatives of patients with definite hypertrophic cardiomyopathy. If the HCM patient does not have a known mutation, then imaging is necessary for family screening because obviously you can't screen the patients for genetic screening. Negative testing does not indicate the patient does not have hypertrophic cardiomyopathy. So family screening strategies to detect hypertrophic cardiomyopathy in the absence of genetic testing includes those younger than age 12 who have a malignant family history, competitive athlete, or have suspicious early onset of LVH, recognizing that the anatomic manifestations of hypertrophic cardiomyopathy with septal thickness over 1.4 on echo typically does not come up until the early to mid-teenage years. And those 12 to 18 years of age, every 12 to 18 months with screening, and over 18 years, every 5 years. But the routine genetic testing at this point plays a minimal role in managing these patients. So we have, in fact, 3 goals of management with these individuals: improving symptoms and quality of life by prevention and treatment of heart failure, AFib, and particular prevention of stroke. And this is done with medical therapy. And in particular, in the U.S. now, the standard of care is to refer to a hypertrophic cardiomyopathy center. We want to prolong survival, prevent stroke, and reduce heart failure with anticoagulation, medical therapy, and ICDs. And increasingly now, there needs to be a multidisciplinary team that includes not only the cardiologist, but the cardiac surgeon, the interventional cardiologist, the pediatric cardiologist, the geneticist, and a wide range of other individuals with skills that can help with counseling and managing the practical matters in these individuals, particularly with regard to counseling relative to pregnancy issues in patients with genotypic or phenotypic manifestations of hypertrophic cardiomyopathy. So there has been considerable progress. There are continued advances that are needed, and in that respect, continued registries have great hope of giving us information, in particular collaborative registries that go well outside of the United States, EU, and we're looking forward to opportunities to participate in the Middle East with HCM registries as well as other registries as well with the ACC. Molecular mechanisms need to be defined, target pathways to prevent the disease manifestations. We want to predict and prevent sudden death, heart failure, and AFib, and devise treatment to fundamentally alter the disease biology, prevent development of hypertrophic cardiomyopathy, and limit the clinical consequences. So with that, I'll conclude, and thank you very much for your attention.